Aortic stenosis. The common clinical scenarios could be young people with a functional murmur with a bicuspid valve or older people with aortic sclerosis versus aortic stenosis. Commonly characterized by a grade 1 to 2 systolic ejection murmur. The symptoms are pain, syncope, dyspnea, and impaired exercise tolerance. Other signs of the LV failure, diastolic and systolic dysfunction. The chest pain could be reduced due to reduced coronary flow reserve, increased demand, and high afterload. Syncope and dizziness, fixed cardiac output, vasopressor response, and you have dyspnea, impaired exercise tolerance, and other LV failure. So we can compare it with other systolic and diastolic murmur, but the aortic stenosis murmur is a typical diamond shape or crescendo-descendo murmur, whereas the murmur of mitral insufficiency and tricuspid insufficiency are not crescendo-descendo, and the mitral valve prolapse murmur, you will see a click followed by the murmur. The physical finding is a murmur which gradually increases as the severity increases. The S1 to S2 distance is reduced and there's a prolongation of murmur. Intensity does not predict the severity of the murmur. The presence of trill does not predict severity, and the diamond-shaped harsh systolic uh, crescendo-descendo murmur, decreased delay and prolongation of the pulse and amplitude, and paradoxical S2, S3, S4 with left ventricular hypertrophy, S3 with left ventricular failure. Etiology is the young patient, think congenital bicuspid, 2% population, 3:1 male-female distribution, coexisting coarctation, 6% of the patient, rarely unicuspid valve by subaortic stenosis, discrete diffuse, middle-aged patient, 4 to 5 decades, think bicuspid or rheumatic disease, old patient, think of degenerative disease in 6th, 7th, and 8th decade of life. The congenital bicuspid valve is the most common abnormality. Rheumatic heart disease and degeneration with calcification are found as well. The normal aortic valve area is between 2.5 to 3.5 centimeter. Mild stenosis is between 1.5 to 2.5 centimeters. Moderate stenosis 1 to 1.5 centimeters. Severe stenosis less than 1 centimeter. Onset of symptoms 0.9 centimeters with coronary artery disease, 0.7 centimeters without coronary artery disease. Echocardiogram will tell the etiology, valve gradient and area, left ventricular function, systolic function, diastolic function, LA size, concomitant regional wall motion abnormalities, coarctation associated with bicuspid aortic valve. The use of Doppler ultrasonography and continuity equation in estimating the aortic valve area for blood flow A1 into V1 to remain constant when it reaches stenosis, the velocity must increase to V2. The Doppler examination of the stenosis detects the increase in velocity, which can be used to calculate the aortic valve gradient or to solve the continuity equation for A2 and denotes the area and velocity. So angina, if the angina happens after the aortic stenosis, the life expectancy is 5 years. If syncope happens, then 2 to 3 years, and if congestive heart failure is there, then 1 to 2 years. The heart failure reduces the life expectancy to less than 2 years. Angina and syncope reduces the life expectancy between 2 to 5 years, and rate of progression decreases at the rate of less than 1 centimeter square. And this is the famous graph which shows the onset of angina, syncope, and failure. Operative mortality of AVR in elderly 4 to 24 per year. Risk factor for operative mortality is functional class, lack of sinus rhythm, hypertension, pre-existing LV function, aortic regurgitation, concomitant surgical procedure, CABG, MV surgery, previous bypass, emergency surgery, coronary artery disease, and female gender. The types of prosthetic heart valves could be mechanical or bioprosthetic, and the historical ones are the caged ball valves and tilting valves, but now we use the bileaflet tilting disc valve. In bioprosthetic could be heterograft and homograft. Heterograft could be porcine, bovine, stentless, and stented. Mechanical prostheses are durable, large orifice area, high thromboembolic potential, and best in left side, and chronic warfarin therapy is required. Bioprosthetic, non-durable, smaller orifice and functional stenosis, low thromboembolic potential, considered in elderly, and breast in tricuspid position. Thank you.